Chapter 10 of this book highlights the orthopedic tests we use for the lumbar spine. And the reason I think this book is so wonderful is because it actually goes into the evidence of the tests that we've been taught or have been told to use. It breaks down the tests based on the bias of the studies that investigated the test to begin with, the reliability, the specificity, sensitivity, likelihood ratios, and the authors give it an overall score for each test, whether there's strong utility in the clinic, moderate utility, minimal usefulness, or because there's not even good studies to go off of, they give it a question mark. So the lumbar spine is an important chapter because, like most patient or clinicians who work in the field of orthopedics, over half of my caseload, my patient load, is patients with low back disorders. Mind you, that doesn't mean they're necessarily presenting with low back pain. They might be presenting with buttock pain or knee pain, thigh pain, feet numbness, etc. But low back pain or low back disorders is one of the major disability producers in the world. A few years ago, depression and low back pain were the top two causes of disability worldwide. And of course, if you listen to me, you should now know that the reason I think low back pain is such a worldwide cause of disability is because it's patently misunderstood and mistreated. I think Robin McKenzie several decades ago got it right when he found that most low back pain is due to mechanical disorders. Joints not moving correctly that can be fixed by moving the joints in the direction that they need. This is in contrast to most of orthopedic care, which thinks of low back pain as kind of more non-specific, not needing a specific movement, but needing general movements, exercises, stretches, stabilization, etc. I know this because that's the way I used to approach a lot of low back pain. Not only did I learn through personal trial and error when I started learning repeated movement testing and using it on myself, but I started noticing that when I used repeated movement testing formulated by Robin McKenzie with my patients, most patients had a specific repeated movement that could help their back get back to normal range of motion, normal nerve tension, normal strength surrounding the musculature of the low back and the lower extremities. But it did take a while to get more competent at repeated movement testing because it's more involved than a quick orthopedic special test like many of these highlighted here that only take a few seconds or minutes to do. And of course, taking a picture is also quite quick in comparison to repeated movement testing, which is really an informed investigation of looking at different movements and how they affect the person's low back disorder. This chapter 10 on the lumbar spine, highlights 32 orthopedic tests that are used for the low back. They give 2 tests a grade of 1, meaning that 2 of the tests out of the 32 have strong usefulness in the office or in the clinic. They give 15 a grade of 2, so moderate utility, and they give 8 tests a grade of 3, meaning minimal utility. For the rest of them, the remainder, the 7 that didn't get a 1, 2, or 3, they gave them a question mark, unknown, because there wasn't enough data to say how helpful this test actually is for clinicians to use or not. And of those 2 tests that got strong recommendation for usefulness in the clinic, one is a prone isometric chest raise test to determine if pain is from the low back. I've never used that test. I feel like the verbal history and other kind of baseline taking can help me understand if the pain is from the low back or from something else, say an organ, like a visceral referred symptom. So that test got a 1. And the other test that got a 1, repeated movement testing looking for centralization. I was really happy to see that included in this book. It is not included so far in the other chapters I've read on other parts of the body. I don't think repeated movement testing has been investigated enough for the wrist, for example, for it to be included in this synopsis of orthopedic tests. But it made me very happy to see that these authors recognize that repeated movement testing, Robin McKenzie's repeated movement testing, is the strongest, as well as that other one, test for low back disorders. And how many clinicians are actually using Robin McKenzie's repeated movement testing? I would say of all the clinicians probably in the United States who have as one of their primary disorders that they treat low back disorders, probably 1 or 2%, maybe a few more, are actually using repeated movement testing competently with their patients. They talk in the brief description of repeated movement testing and centralization as looking for discogenic symptoms. They mention there's multiple directions of repeated and range movements that could be used, including extension, flexion, and side flexion. I would agree with extension and flexion. I don't call it side flexion, I call it side glide. Obviously, there are combination movements as well. They're just mentioning a few of the examples. They say movements are generally attempted for 5 to 20 repetitions and looking for centralization or peripheralization. Now, in a perfect world, you could see change that quickly, but I will say in the clinic, in 5 or 20 repetitions, you're not probably going to see a peripheralization response or a centralization response. I'm looking for it, and I'll probably do more than 20 reps to try to achieve a change like that, but that repeated movement testing is generally continued at home, and that data that's performed or that's gathered over the performance of 100 repetitions or 60 repetitions throughout the day is really helping us to inform, is there centralization, is there peripheralization, or is there just improvement in symptoms but not in that pattern of moving centrally or proximally. So they looked at two studies, Laslet's study and Donaldson's study, and they found that the specificity was either 94 or 64, the sensitivity was 40 or 92, and there was a low risk of bias with these studies, and that's why they gave it a grade of 1. So I think I heard Mark Laslet say on a podcast maybe last year or a few years ago, if a clinician who treats low back disorders doesn't know repeated movement testing, they have no business treating low back disorders. And I 100% agree. And that's why after a few years when I was working in clinical practice, having suffered my own herniated disc several times, I decided to take Robin McKenzie's courses through the McKenzie Institute. And it clicked for me. I wasn't in pursuit of something to help me. I was just in pursuit of something that would help patients achieve better results with low back disorders, and inadvertently learned how to fix my disc problem that had come and gone many times and caused a lot of problems in my life, including 6 months or 10 months without being able to run because of the pain, not being able to sit sometimes, not being able to sleep. Anyone who's had low back disorders know that sometimes it can be very interfering with one's life. But clinicians, I urge them to learn repeated movement testing through coursework or through finding a mentor or reading the textbooks. There are 5 textbooks that go through Robin McKenzie's repeated movement testing. 2 are focused on the lumbar spine. For patients, however, struggling not only with low back pain, but also all those other symptoms that are in the buttock down to the toes that haven't been correctly identified and solved, find a clinician, maybe who's certified or diplomaed in MDT, which is Mechanical Diagnosis and Therapy, Robin McKenzie's Mechanical Diagnosis and Therapy, which means repeated movement testing. Mechanical diagnosis means looking for a mechanical problem, and then mechanical therapy is solving it with specific movements. That, again, is in contrast to doing some planks, getting your QL released, foam rolling, strengthening, stretching the muscles of the hip and thigh that people say are pulling on the low back and causing it to be a problem, in conjunction with repeated end range movements that we use when we find or look for the direction that the patient needs. We are assessing if there are other things in that patient's lifestyle that are kind of antithetical to that. So if the patient needs extension, for example, of the low back to mechanically get the low back well again, we are going to attempt to minimize a lot of flexion. Sometimes that's just in the healing therapy process. So we're going to restrict slouch sitting or maybe a lot of bending at the gym, for example, during that process. But oftentimes it carries over after therapy is done into a maintenance strategy, because we can hypothesize or prove that imbalance of flexion through the lumbar spine and extension through the lumbar spine is a contributing factor to that person's mechanical disorder. But we have to formulate a maintenance and prevention plan individually for the patient that works. Sometimes it's subtracting things from that patient's life. Sometimes it's adding things. Sometimes it's both. But if you are struggling, please find someone who knows repeated movement testing. It's one of only 2 of the 32 tests in Chapter 10 that get a strong recommendation for usefulness in the clinic when it comes to low back disorders. That's what I find clinically. I find most of these other tests, which therefore kind of lead to a specific treatment approach, are not based on good evidence.